welcome everybody to this wonderful wrap-up of this week, the Bias Women's Health campaign to empower and enable women to seek the best health care they possibly can, and to discuss the advancements that we have made with women's health. My name is Laura Dowling. I'm a pharmacist. I have been a community pharmacist for 20 years. I am joined with three amazing ladies who are experts in their field. We have Dr. Caoimhe Hartley, who is a GP and menopause specialist. We have Geraldine Gannon, who is the Assistant Midwifery Director in the Rotunda Hospital. And then we also have Professor Maeve Eogan, who is an obstetrician and gynaecologist, also in the Rotunda. So welcome, ladies. Thank you so much for joining us. We are going to have an amazing discussion about women's health. And I think that this week has just been really good. I've got so many messages from women saying they feel that they know an awful lot more about what they can get from their healthcare practitioner, what's out there for them, and you know, just enabling them and teaching them about all the things that are available to them now. So I think without further ado, we'll begin with Caoimhe. Caoimhe being a GP and obviously at the coalface of I suppose all the issues that that occur with women and their health. So Caoimhe, would you want to tell us just a little bit about yourself and your practice, and then we will go into the contraceptive scheme?
Sure. So yes, I'm a GP by trade. And I've always had an interest in women's health. I did some training abroad for a few years when I lived in Canada. And then when I came home, I opened a dedicated menopause service, and we have a clinic in Dalkey, County Dublin, which will hopefully be expanding to more general women's health over the next year or two. And I, with Dr. Vicky O'Dwyer, run the menopause service through the Rotunda Hospital, which is up and running now for the last few weeks, which is great.
That's wonderful, and it's definitely, the menopause is definitely something that's needed. Like this is a train that has been coming down the track for a number of years now. So it's wonderful to see that there is, you know, specifically devoted clinics to it. So well, we discussed the contraceptive scheme and how you have seen that you know, evolve since its inception, and your thoughts on it, and what's available to women aged 17 to 25, what they can expect if they go to see you.
Yeah, I mean, contraception, if you think about it, is probably one of the greatest sort of inventions that's happened in our, you know, in our lifetime in this century, and has been massively life-changing and empowering for women. It's such an important value. It should be a absolute basic kind of human right for women to be able to control their reproductive health. And what's great about contraception now, I suppose, is that we have so many different choices and different options. It's such an individual thing. Some women get on really well with one option, with a pill, for example, and for somebody else, they might want something more long-acting, like an implant or something like an intrauterine device. So the initial consultation is really important. That's usually with your GP or in a women's health centre, to kind of explore that and see what contraceptive option really suits the person who's sitting in front of you, their lifestyle, their background medical risks, and what would be best for them to use. And then I suppose what we really needed was access then, once that decision had been made. And that's what's really changed, courtesy of the last budget, which is great. So what they've introduced is free contraception. So for women from their 17th birthday, basically, until they turn 26, so 17 to 25. And what it entitles you to is, provided you have a PPS number and you have an address in Ireland, if you're a woman or a person with a uterus, you can attend your GP. There are some women's health centres, and you can attend to have that initial consultation, that discussion about what you want to take or use, and your prescription is also covered, and a follow-up visit is also covered as part of that. And for someone who maybe goes down the route of getting an intrauterine device, for example, the insertion of that device, the device itself, the follow-up related to that device, all of that is covered. You don't need to have a medical card. You just need to be aged between 17 and 25. And I think they're hoping to expand it next year from September 2023 to include women from the ages of 16 up to 30. So hopefully that's coming down the line, which should be a really great step forward as well.
Absolutely, it's wonderful. Like, we're really making such great progress. And actually, I just saw from the HPRI today that the Marina can say in situ for 8 years now as contraceptive, as a contraception. So, which is really good. So, and then, you know, I think it's important that people realise that they can go for those follow-up appointments as well to make sure that the IUDs are in place and that, and that it is for free, which is just wonderful. And then obviously they come to the pharmacy, and all they need again is their PPS number, and they can get their medicines for free. So it's all really good and really promising, and obviously we'll all be pushing for it to be to be pushed out to the older ladies as well, like up to 30, and then possibly beyond in the coming years. So can we discuss the menopause clinic, the new one that has opened up in the Rotunda Hospital, Caoimhe, and the part and the role that you play in that, please?
Yeah, so similar to the clinic that was opened in Holles Street several months ago, we are a dedicated menopause service. It is mostly GP referrals or referrals from other consultants. And women are referred through the electronic, what's called a health link system, which is through the system on the computer that most GPs use, and are then seen in our clinic. I have a wonderful advanced nurse practitioner. I have a wonderful physician's associate. I have a GP fellow who might be starting with me. So we're a real team, which is great. We've great admin. Dr. Vicky O'Dwyer is the consultant gynecologist who works with us. So it's a really good team approach. And the gynae OPD, the outpatients department in the Rotunda, is fabulous. I have to say, I sort of was like, really, I'm working here? This is amazing when I walked in on the first day, because it's just set up so well. There's great access to radiology and investigations for women who need that. So essentially what happens, it's a bit like my own clinic. You're referred in by your GP. We meet you. It's a 40-minute consultation is your first consultation. And
brilliant. That is just wonderful, isn't it?
So it's not a sort of you're in and out in 2 minutes. We really do explore, the impact that these symptoms are having on your quality of life, your background, medical history, etc. And talk about, I suppose menopause is quite broad. So you end up talking about, well, look, not everybody needs HRT, but some women will. There are non-hormonal options. We see a lot of complex care. So maybe women who've had a history of breast cancer, for example, or other medical conditions that their GP might feel not totally comfortable prescribing for. And we explore all those options with them. We talk about long-term screening, like bone density with a DEXA, for example. We talk about cervical screening and mammogram screening and all of that. Okay. And then hopefully, I think we're talking now about being able to link people in with smoking cessation programs and different things as well, just taking a really holistic approach. And then we usually bring people back after 3 or 4 months for a review, and we go from there. But it's been really, really busy, which is a good sign. I think probably reflects the demand that's out there, which is good, because then I have a job, which is also good. So
I can imagine. And is it a free service, Caoimhe?
It absolutely is. Yeah,
okay,
it absolutely is. Yeah.
And is the waiting list long, just for people to...
So at the moment, it's probably about 6 to 8 weeks.
Okay.
And then I suppose it just depends on demand and how that goes. Yeah.
Yeah, I'm sure there'll be lots of it, and the more people that learn off it and that get help, they'll be telling all their friends. So I'd say you're going to be inundated.
Again, at least that's good. Then the Rotunda will continue to employ me, so that's good. I'm happy. But
and that's what's great about having the dedicated ambulatory gynae clinic, because space is there to expand the service. Like you said, you have the advanced nurse practitioner, Jane, and we have for a company as well. Will be another advanced nurse practitioner. So the service, there is the ability to expand, which is phenomenal. Great.
Yeah, that's wonderful. It's wonderful. Professor Maeve, I might bring you in now. Welcome and thank you very much for joining us. Can you tell us a little bit about your role in the Rotunda, what you do and what your clinic does too?
For sure. So I've been a consultant obstetrician and gynecologist in the Rotunda since 2009, and my particular interests include the area of prevention and treatment of pelvic floor injury after somebody has a baby, management of ongoing symptoms in that regard, as well as looking after people with addiction or infectious diseases in pregnancy, as well as being the national clinical lead for the sexual assault treatment unit services. So I have quite a diverse role within the Rotunda, but it's amazing how the various teams often interact, and actually it's so great having Caoimhe on board as well, because I think one of the things that has done, and the advancement of investment in women's health services, it has actually kind of broken down barriers between primary care and hospital care. Patients will often consider them two very separate entities, but ultimately we're a team looking after people together. And I suppose we were all greatly rewarded, I suppose, by the campaign to repeal the 8th Amendment and being able to expand termination of pregnancy services within our health service. But I suppose because so much of that was in primary care, that interaction between primary and hospital care really developed after that. And that has continued with the Women's Health Strategy, the Women's Health Action Plan, the step change investment in women's health over the last number of years. And I think really as a team, we're hopefully all working together for the betterment of women's health across the ages. And actually, as Caoimhe talked about contraception within the primary care facility, but also, a 21-year-old is going home from hospital having had a baby, we can prescribe and administer long-acting contraception, or indeed give her a prescription, for example, the combined pill or the progesterone-only pill. And all we have to do is write on that prescription, please administer within the 17 to 25 contraceptive initiative. So that means people aren't actually have to, when they have their small baby, they don't have to prioritize getting to the GP straight away for a prescription. They actually have that prescription on leaving here. And I think all those things just help, looking after your health can be a full-time job for some people in terms of illnesses they may have, and anything we can do to sort of optimize access and make our care a little bit more efficient is hugely beneficial,
Absolutely. But it seems like as if it's really gathered pace in the last year or two. And I know there's been so much work being done in the background that the public probably didn't know about. And now it's like, it seems to be all coming together, and it's like, gosh, with services, which is just, it's absolutely wonderful. Could we speak a little bit about the sexual health, the sexual assault unit that you run?
Yeah, so I'm the national clinical lead for the sexual assault units. There are 6 around the country. So there's the Rotunda, which was the first one, set up in 1985, which really is quite a long time ago. And that was the forward thinking of our master at the time, George Henry, who went to Australia, saw this service. And back in 80s Ireland, I mean, it was really very socially aware of him that he decided this was something the Rotunda needed. And as a voluntary hospital, the board of the Rotunda supported developing of that. And then what happened was registrars and other doctors came through the Rotunda, saw this service, went and worked elsewhere and said, gosh, we don't have this service where we are in Cork or Donegal or whatever. So there's now a unit in Dublin, Mullingar, Galway, Donegal, Cork and Waterford, meaning that no person in the country is more than 3 hours from their nearest sexual assault unit. And I suppose that's always a bit of a balance, is 3 hours too far? Is it, should there be more? And I suppose we're constantly looking at that to ensure that we've got good service across the country. But I suppose the thing about the sexual assault units is they have to be available 24 hours a day, 7 days a week, 365 days a year. So you need to have a sustained staffing model that gives you trained personnel available in that time. So if you have too many, potentially you might have some that aren't available on certain days, which isn't responsive to what the person needs. And the same thing, we had a very traditional model where it was a doctor looking after the patients in the SATU, supported by an assisting nurse. But in the last over a decade now, we have specialist nurses and specialist midwives, clinical nurse specialists, advanced nurse practitioners, again, breaking down those silos, having people who are appropriately trained to look after the patients according to the care the person needs, rather than to the particular title of the practitioner as such. And as Caoimhe says, we also have a team of people, colleagues from Rape Crisis who provide the psychological support, linking with infectious disease personnel to ensure that we give people the appropriate infectious disease preventative treatment at the time they come to the sexual assault unit, and giving them options. So some people will come to us having come through An Garda Síochána, other people will just come to us wanting a health check, ensuring they don't get pregnant after this, ensuring they don't get an infectious disease, but they don't want to go to An Garda Síochána. So, as Caoimhe and Geraldine say, it's very much bespoke to what the person needs. And that's what our health service should be. It should be person first.
Yes, absolutely. And sorry, does kind of woman just walk in and
yeah, it is better if somebody schedules an appointment, because we can give them the right appointment according to what they need. But for people who have reported an incident to An Garda Síochána, that appointment is quick. It's generally within 3 hours of the request. So it's because DNA evidence, you know, within 7 days of an incident, the DNA evidence may be very relevant. DNA evidence deteriorates quickly. It's a little different if someone comes to us maybe 2 weeks after an incident and just wants to come for a checkup. That may be a sort of a next working day type scenario. But in general, if somebody's coming to us soon after an incident, we try and see them as soon as possible. And that's why we have a broad geographical spread of SATUs in order that people can get the care when they need it, where they need it.
Okay. Well, that sounds great. Can you tell me about what the types of things that you see in the See and Treat Gynaecology clinic? Because you know, I think that it's very interesting.
Yeah, for sure. And I mean, that the traditional view of a gynecology clinic was a GP referred a patient with a particular gynae problem, you know, pain, prolapse, heavy periods. The person came, met with the doctor, and there was a plan made, and the patient had to come back. So they often left the clinic not with any great diagnosis or solution. They may have a diagnosis or solution, but they may not. They may have to come back for something. So the way the See and Treat clinics work is people with particular symptomatology, when their GP refers them in. So for example, a 45-year-old woman periods who's tried, you know, tablet A, B, and C from the GP. That woman now needs a hysteroscopy. We need to look into their womb to see, is there any pathology there causing the issue? And then at that same time point, for example, if she wants, put in a Mirena coil, which would be very helpful for mitigating the symptoms of her heavy periods. And that can all be done at one visit. So the woman walks in the door with her symptoms and leaves having a diagnosis and a plan. So that's increases the efficiency of the service and means we're able to look after people. And indeed, the hysteroscopy clinic in the Rotunda increased their productivity last year by something like 40%. You know, they saw more and more people as they got better and better at providing an efficient service. And just, you know, the mental health benefit of knowing you don't have anything, you know, serious or life-threatening, and having a therapy instigated straight away is not to be underestimated, as well as the sort of efficiency thing of having kids minded, taking time off work, making the arrangement to get to the Rotunda. If you only have to come for 1 visit or 2 visits rather than, you know, 3 or 4 to get your remedy, you know, that's surely got to be beneficial for everyone.
Absolutely. And can we talk just a little bit about the regional fertility hubs?
Yeah, so they're a new thing as well. What used to happen was we had a catch-all of gynae referrals. So if Caoimhe saw somebody with infertility in her GP practice, or she saw somebody with period pain, they all just got referred in. Now we're trying to be much more, you know, much more bespoke to what the person needs. So the fertility referrals will go to a particular waiting list, meaning that people aren't waiting, you know, a very long time to see somebody, because, you know, fertility is time sensitive. And if somebody's referred by their GP at the age of 40, and if there's a 2-year waiting list, well, you know, they may have aged out of, you know, without being too scaremongering about it, but they may have aged out of fertility. Whereas if they'd been seen at 40, there might have been a benefit. So triaging the referrals in appropriate way, having a separate slot as such for fertility, and enabling efficient delivery of those fertility services. So at the moment, somebody will come in now to the fertility hub in the Rotunda. They see a fertility specialist straight away. They don't see, you know, they don't have a routine gynae visit and then have to be referred to a fertility specialist. So, you know, a couple of years ago, people might have been waiting 2 years for a fertility appointment. Now they're waiting a matter of a few months. And obviously, because of all the training and everything within the ICGP and of primary care, the GPs have done so many of the investigations first that when the person comes, they really know what they're going to get, and, you know, move towards a diagnosis and a plan much quicker. And that's even going to develop further. You know, there's a hope that there's an ambition that each of these fertility clinics, fertility hubs, will be providing IUI, which is, you know, assisted fertility short of IVF, and ultimately, hopefully by next year, there's, you know, lots of plans going towards publicly funded IVF. So there is a lot happening in that space as well. So certainly nobody's standing still. You know, they're looking at where we've come from, but also where we need to get to really make this bespoke.
Yeah, and I think it's wonderful that fertility is part of this conversation, because for too long it was, there was a negative connotation towards fertility and towards women, like you just used the term, like aging out, or getting older and seeking to and wanting to have babies. But that's life, that's society, and we need to move with that and help women and couples to get the treatment that they need in a timely fashion, which is seemingly.
And even the referrals for the fertility hubs are triaged according to, if somebody is over 38 or under 38, which is good. It gets people into the service quickly, but obviously, not too quick, so that natural fertility can't be supported as well.
Okay, no, that's wonderful. Now we're going on to Geraldine Gannon, who is the Assistant Director of Midwifery in the Rotunda. And Geraldine, if you could just tell us a little bit about yourself and your areas of interest.
Hi, yeah, I am a Sligo woman in the Dublin Maternity Hospital. So I've been in Rotunda now for nearly 20 years. I trained here as a student midwife. And as Maeve will tell you, the Rotunda just gets under your skin. 20 years later, here I am still. So I love working there. But I've been director of midwifery now for 4 years. But before that, I worked the majority of my time on the delivery suite. It's a joy in the hospital. It's a very, very busy hospital, but it's a great place.
My own mum worked in the Caoimhe for years, so a little bit of rivalry there,
No rivalry. We all try to work together. And
I know.
At busy times, we'd love to be able to share the load a little bit, but
I know. I had a lovely chat about breastfeeding and medications with Dr. Fife last night. Would you like to tell me a little bit about the breastfeeding program that has been been rolled out, and our increase in lactation consultants, etc.?
Yeah, it's great. So we've got funding for 24 extra community-based lactation consultants. Obviously, all trying to promote breastfeeding. For the benefits of both and baby, are huge benefits. And we know by our initiation rate, our initiation rate is quite high. Then it's 70% of our women start off breastfeeding, drops in when people go home. So, and women will tell you that support is just a phenomenal. It's a big need that they require. Through COVID, for whatever reason, the breastfeeding groups all stopped. Those supports that were there for people in the community stopped for a long time. So our breastfeeding rates did get there. So having extra supports, extra consultant midwives is phenomenal. Now in Rotunda, we have a lot. All midwives are trained in breastfeeding support, but we have about 24, 25 lactation consultants working in various areas throughout the hospital. We're also very lucky that we have a really good community team, and so they can see women in their homes and provide support at the community. Definitely link again with primary care, have that link whereby women can get the support once they're community midwives, hand them over to community. Having that link there for support is phenomenal. So yeah, great. It is great. We also have a new post in the this year, whereby our most vulnerable babies have now dedicated lactation consultant based in our NICU department. Again, they have them home as well.
And how long can a woman expect to be able to access a lactation consultant post-delivery, once she returns home?
We don't put time on it. Okay. So obviously they have the access through call in. We have a postnatal service where women can just drop into a clinic on Tuesday mornings. They can ring and get support from the lactation consultants at any time. So we don't put time on it. We do try and link them then with their community, Lalit leagues, or whatever other services are out there. We provide numbers. HSC have a great website for supporting breastfeeding, where all the local community support groups are there. So all those are provided to the women as well before they leave.
That's great. And can we talk a little bit about the maternity bereavement experience survey that has been, you've done, and the work that Rotunda is doing. I attended an event there about the it was in Dublin there recently, for the Rotunda Hospital and the bereavement services that you're trying to provide for mums and dads and families.
Yeah. So they've run a national survey. It's the first bereavement national survey, whereby any woman who has sadly experienced second trimester loss, be it stillbirth, miscarriage, or early neonatal death, you can go on, opt in to take this survey. Takes them through their experiences. It includes all 19 maternity hospitals. They could just go through questions about the diagnosis, admission to hospital, experience, basically the journey throughout their pregnancy loss. It's a really good information for us. You know, we will learn an awful lot from these women who will provide their story. They will highlight things that we've done really well, and then they will obviously highlight things that we need to improve on. So a lot of information, valuable information to improve services. So we should have the results of that survey late next year. And I know in Rotunda, we're always asking our women we can improve our services. So like I said, there was a fundraising there in September for our suite. We're trying to just develop a room. Obviously, women need to get their care while they're going through their cost, but we are trying to improve services. We can have a home from home type situation where if they want to bring in their family members, their children, and just get a little more support for them.
Yeah, it's lovely. I saw it, and I've seen families that have been helped by, the caregivers and the care that you provide people who are going through such a difficult time. It's just so important that there is that dedicated service for them. So I think that we'll all be looking forward to the results of that survey come 2023. Ladies, one thing, sorry, that I didn't discuss, Maeve, with you, and it's something that's really coming to the fore now as well. We're speaking a lot more about it, is endometriosis. I'm sure, Eva, you can give me some information on this too. But endometriosis is one of those things that they say it can take up to 8 years for it to be diagnosed. Women go through an awful serious amount of pain. They're just, they've been told over the years that's just it. It's women's issues. Go home with a hot water bottle. What's being done to improve endometriosis services in Ireland now?
Yeah, again, as part of the Women's Health Strategy and the Women's Health Action Plan, there has been a commitment to have advanced endometriosis services for people with more extensive endometriosis, and indeed to sort of all of those endometriosis services are around the country. So general gynae clinics that then feed into the specialist endometriosis clinic, which then feeds into these super regional services. So at the moment, I think the plan is that that's Tallaght and Cork, where there's advanced endometriosis care available. So that's, endometriosis, as you probably know, it's where the lining of the womb tissue is growing outside the womb, and it can actually invade into the area of the bowel or into the bladder, and the surgical management of it can be quite complicated at the severe end of the spectrum. And it's not all within the remit of the gynecologist, even the very specialist gynecologist. So those super regional centres, for example, would have input from urology, from surgery, from specialist physiotherapy, from endometriosis specialist nurses, to really support people at that more severe end of the spectrum. But even at the more benign end of the endometriosis spectrum, you're right, getting a diagnosis can take some time. And you would hope that all of these improvements in women's health, access to women's health services, shortening waiting times, expanding gynae services, will help people achieve a diagnosis early. But the other thing is that sometimes endometriosis doesn't need an intervention to make a diagnosis. Some of the very effective treatments include things like combined oral contraception. So sometimes it's just a matter of somebody having a history taken, having examinations and ultrasounds undertaken, and then having combined oral contraceptive prescribed, which now, if they're up to 26, they can have free of charge. And that also means that those symptoms will improve. Even, it's not that everybody needs a laparoscopy, but hopefully if they do need a laparoscopy, they'll be able to access it a little quicker than they would have been. Indeed, one of my recently returned colleagues has just come back from the UK, and her specialist area is pediatric and adolescent gynecology, and she was saying they're making a lot of diagnoses based on MRI. So holding people away from laparoscopy and ensuring they don't have to undergo general anaesthetic and stuff. So what you can see is this is a moving field, and the investment in women's health is hopefully benefiting the entire health service, because if people are waiting a long time for diagnosis, back and forth perhaps to their GP, and that's hard on everybody, but there's still lots to do. Nobody's resting on their laurels. We've still a ways to go.
Absolutely. And I think what's really important to acknowledge is, we're talking about women's health here, and obviously the whole movement is towards women's health. But if we look after women, we're inevitably looking after the rest of society, because women's relationships, they're, the way they can care for their children, the way they can work in the workplace, their intimate relationships, if their health is being minded, then all of those fall into place too. So it's really important that this is embracing, healthcare for society as a whole. And I think if we acknowledge that, then we're really going to go places with it. And I think it's only going to get better. And it's wonderful to have these discussions and have these chats and to see where it's going as well, isn't it?
Mm-hmm. Yeah, well, what they say, women and girls prosper and entire communities benefit.
100%.
So that's what we're
so true.
That's what we're all about.
Absolutely, and I think that we can probably that's a lovely way to end it, unless any of you ladies have anything that you would like to say that we maybe missed.
Thanks a million for moderating the discussion. It's been fantastic, and well done to all the team on Bias. All of the things all week have been so insightful. Even listening to things of people that I work with every day, everybody has so much to offer, and it's great to take that time to have the chats.
Absolutely, and I think it's so important that people realise all the specialities are talking to each other, and they all feed into each other, and it's just so wonderful that we do have this team and this seemingly really great movement for healthcare in Ireland. Thanks, ladies. Thanks so much. Thanks everyone for joining.